the Academy of Biomedic Dentistry. We got Dr. Graeme Milicich coming to us all the way from New Zealand. How's it going, Dr. Milicich?
That's going very good, thank you. We're sitting here in the middle of summer. I believe you guys are in winter, so some of you are getting a bit cold, but we're doing good.
Yep. We're going to get this party started here shortly. And Dr. Graeme Milicich, he is our guest of honor today, and he'll be going over a whole bunch of cool stuff. I'm going to let him kind of introduce what he'll be talking about today. But before that happens, I do want to say, Dr. Mark Lazar, if you wouldn't mind introducing our guest and letting everyone know what they'll be viewing today and how and what they'll be seeing. Now's the time.
All right, it's my pleasure. Thank you, Matt. All right, so today I have the very distinct pleasure of introducing Dr. Graeme Milicich. He's a renowned international lecturer, and he does a lot of hands-on training, a lot on fracture mechanics and how to identify these fractures and how to treat these teeth in the most conservative way possible. A lot of that he will be going on this webinar today, and also the other one that's coming up in a couple of weeks. Dr. Milicich graduated from the University of Otago in New Zealand. He has more than 40 years of clinical experience, and that was before retiring recently from private practice. But he has been a great mentor and advisor to us and also to our friends at the Bioemulation Group in Europe. He holds a diplomatic status at the World Congress of Minimally Invasive Dentistry, and he is a master of the World Clinical Laser Institute and a founding board member at the New Zealand Institute of Minimally Invasive Dentistry. And Dr. Milicich has published numerous peer-reviewed dental articles. Among them is clinical presentations of stress distribution in teeth and the significance in operative dentistry. That one I'm mentioning because that is one of the key articles that the science of biomedic dentistry is based on. When I went to the Almond Pellery Center, he basically gave us 27 key articles and said, this is one of the key articles that you must know inside and out to understand the mechanics of biomedic dentistry. So it's amazing to meet the person behind that article. I've had the privilege of hearing him speak in person at our past annual conference, and I'm very happy to have him here at our webinar. And it's a real treat to have him with us. I mean, you guys will see when you listen to what he has to say. It's amazing. So without further ado, I would like to turn this webinar over to our friend and our mentor, Dr. Graeme Milicich.
Right, thank you very much. Now, do you want me to hit the share screen now, and it's going to turn you over to...
Well, one second.
We got that?
1 second, Graeme. Yeah, I just wanted to let everyone know that I'll be dropping a poll question here shortly, just to make sure that we know that everyone is attending. I believe that's correct, right, Melissa? We have to drop a poll question at the beginning and at the end. So somewhere in the middle here, I'm going to be dropping a poll question for everyone. And please, if you're getting CE, please answer that question. It's going to be a trick question, so enjoy that. All right, and in the meantime, Graeme, go ahead and get started. And if you see a little poll come up, everyone, go ahead and fill that out.
Right, so has everyone got that? Are you seeing the main screen now? Right, yes. Well, welcome to the lecture. What we'll be talking about today is going back to the grassroots of what led us to biomimetic dentistry, because if we start looking at how Mother Nature put our teeth together, what we've been doing with we'd say modern dentistry is actually destroying teeth rather than fixing teeth when you look at how teeth fail. So if we go back to the very beginning, the ultimate goal is to avoid growing cavities at all if we possibly can. So this lecture is all about how to protect an erupting tooth to minimize the potential for it to develop decay. So this is more about maximum intervention in the decay process and minimal invasion into the tooth structure to try and set teeth up to last us for life. So what will you learn out of this today? You'll learn how to diagnose fissure decay accurately, how to use Caries Detection Dye in decay diagnosis, using lasers to diagnose decay, something like the DIAGNodent, using Air-abrasion to enhance adhesion, and getting your heads wrapped around what glass ionomers can do in the way of prevention and protection for tooth structure. So effectively, a dentist is one of three things. Initially, we should be a doctor of dentistry. In other words, we should be dealing with the disease processes. And the reality is there's only two processes we have to worry about. One is caries and the other one is perio. Those are the two essential bacteria, biofilm-driven diseases that as a profession, we're supposed to be the world's experts on. So once you get the prevention program into your practice, then the rest of this starts to get a little bit easier. Then basically we're an engineer. We have to start putting damaged teeth back together. And then there's the last part of dentistry, which is the fun bit, is we can become artists. And particularly when you start playing around with direct composites and you want to do high quality composites or do high quality ceramics, that's the artistry side of dentistry starts to come into play. But effectively, we've been, as a profession, we've not been treating the disease, we've been treating the symptoms. So these cavities are simply a symptom of a diseased cariogenic biofilm. So we can fill these cavities, but that's not going to change what the biofilm was doing. So here's the same patient. This patient here was 14 years old and had 14 cavities. But these are simply a sign of a diseased biofilm. And much as you can fix the cavities, until you target the biofilm, the patients are going to come back every year with more cavities. And this is the frustrating part of dentistry. So when you see something like, if you see a patient developing even a single cavity, diagnostically, that means they are at high risk. They have a diseased biofilm. Otherwise, they wouldn't be growing any cavities. Yeah, why is this thing frozen?
I'm going to launch a poll here real quick while we take this pause. If everyone could please fill out the poll you see on screen, that would be great, especially if you're taking CE. I'll leave it up for about 15, 20 more seconds, and then we can carry on. And if you have any questions, please make sure to put them inside of the chat. And if you are getting CE, there is a code in the chat right now. Please copy and paste that or write that down, because you're going to need that for when you apply for your CE credit. And I'll drop it in a few more times, but make sure you write that down. Okay, so I'll be ending the poll now. Carry on, sir.
Right, so I hit this end poll on the bottom. No, how do I get this to go away?
I just ended it. It should be gone. Do you still see it?
Yeah.
Here, I'm going to end it again. Hold on. Hit the little red box so it disappears for you.
Aha, gotcha. On the top. Okay, it was separated from the actual text box. So
anyway, well, I got to keep you on your toes, you know?
I'm a computer idiot, but anyway, we survive. So effectively what we're looking at when we see a patient like this is we know they have got a diseased biofilm. So we can fill all the cavities we want, but we're not going to fix the primary problem, which is the diseased biofilm. So cavities are a result of biofilm disease, which is one of the most difficult things for us to treat as a profession. Because why do some people have a healthy biofilm and others have a diseased biofilm? In other words, I'm sure you've seen these patients come into your practice. They're basically growing cauliflower all over their teeth, and yet they've got no cavities. And you get other patients come in and you know they've brushed and they floss, they've got a lovely clean mouth, but every year they've got more cavities. Because you really only need 3 layers of bacteria in a biofilm for that biofilm to be able to damage teeth if the wrong bacteria are within the biofilm itself. So just to show you why biofilms turn ugly, now we just got stuff over my, is this study, and you look when it was, 1989. This information's been available to the profession since that time. What they did here is Marsh and his group, they took a culture of 9 to 10 species of oral bacteria in which MS and LB were less than 1%. Then they pulsed it daily with glucose for 10 days, but they maintained the pH at 7. In other words, they kept the liquid neutral pH. And at the end of 10 days, MS and LB were still less than 1%. Then the next experiment was they pulsed this culture with glucose and allowed the pH to drop, and then raised the pH after about 6 or 7 hours, raised the pH back up to neutral. And because they had allowed the pH to drop, what happened is the low pH environment killed off the healthy commensals within the culture, and MS and LB, because they're acidogenic and aciduric and they tolerate this environment, they grew to 55% of that culture within 10 days. So this is the primary selection pressure for a biofilm to become diseased, is to low pH oral environment. Now, sadly, ceramics and composite and amalgam do not treat a biofilm. So you can pour it, you can do as much dentistry as you like in a diseased mouth, it will continue to fail. So what we're really desperately trying to do is keep the oral environment healthy so that you end up with a mouth like's on the right rather than the one that's on the left. But a drill composite and porcelain doesn't heal a diseased biofilm. We have to elevate the pH to get it to settle. So caries management, there's 3 basic steps. One is identify the diseased biofilm, the risk factors and risk behaviors. And secondly, educate and motivate the patient. Now, that can be a challenge sometimes. And then we have to treat the diseased biofilm. We've got to train it back to health. And the way we can do that is elevating the pH. Now, we can't force this process. We have time. You have to create the right environment. And it takes, on average, it takes about 6 months to get someone's biofilm back to healthy. And the product that I've been using that's been really, really helpful has been the whole carie-free range of products. And that's from a company based in Oregon. So if you go online and look at cariefree.com and they've got a whole training program teaching you how to use these products. But until I started doing this, I struggled to get good results for my patients. Now, it's pretty much, if they will comply with the protocols and do a little bit themselves in the way of managing their diet and oral hygiene, we get patients I had patients that used to run with 4 or 5 new cavities a year. And once we've got them onto this program and got their biofilm healthy, they became disease-free for over 10 years. There's nothing motivates a patient more than being able to come to the dentist and just get a pat on the back and you can send them away saying there's nothing wrong. But the interesting corollary from that is a lot of people say, well, you're going to do yourself out of work. Well, what happened in my practice was there were a lot of patients who weren't prepared to spend the money on the top end options for dentistry because they knew they were going to fail. They knew in their heart that they had a problem. Once we got their biofilm healthy, they started approaching me. They said, you know, all that stuff you've been talking about in the past, can I have that done now? And so what happened is my practice actually once I started managing the biofilm disease really well, my practice exploded. So if we're going to try and protect teeth from the attack that can happen from a diseased biofilm, because we can do mechanical things to help protect the teeth. So we started doing resin sealants. That's what I got to do at dental school. But have you ever noticed you can put 4 quadrants of resin sealants in place and they come back and there's a couple missing after a year? You did everything the same. So the question you have to ask is what went wrong? And it all comes back to when a tooth first erupts. It basically is acid susceptible, immature, highly substituted carbonated enamel. And the conundrum is a tooth requires cyclical acid attack to allow these carbonates and metallic ions to be dissolved out and then remineralization via saliva and in the presence of fluoride to produce hydroxyfluorapatite. But that only works to a degree. If you've got a very aggressive biofilm, you're not going to be able to manage it. Now, there's something else that's been around for a while now, and that's CCP, ACP from GC, tooth mousse. And there's two things could possibly be happening with that product. It could be helping with remineralization, but I believe also because it's a neutral pH, it's actually helping maintain an elevated pH, which is letting the biofilm mature into a more natural state and become healthy rather than diseased. So if we look at the Demon-Remin cycle, essentially this is a white spot lesion, and this is the interprismatic spaces that are being opened up by acid attack. And it creates this microporous surface where plaque acid can reside and continue dissolving the tooth. And this is what, there's 2 ways that early aggressive caries can attack the tooth. It can attack interprismatically, or it can actually dissolve the core of the prisms out. So you get these two different processes that look the same clinically. They're white spots, but when you look at them at close level, you start to see that they have different presentations. This one on the right is actually a very aggressive, very low pH environment to produce that. So if we look at an erupting tooth, it has, this is what we get when the tooth is erupting. You have a lot of contamination from metallic ions and carbonates, which are a lot more soluble. They dissolve at a pH of 5.5. If we can get this converted into fluorapatite, it dissolves at a pH of 4.5, which is why fluoride helps protect teeth from the decay process. So this comes from mineral-rich saliva, the presence of fluoride, and then the cyclical demineralization, remineralization cycle. So if we look at what happens, here's the carbonated apatite in a low pH environment, partially dissolves the crystal, and then in the presence of calcium and phosphate in the saliva and fluoride, it will remineralize with a fluorapatite veneer over the crystal. Now you can actually facilitate this process by placing glass ionomer on a cleaned erupting tooth surface. So that does two things. It becomes a source of fluoride for this remineralization process because it acts as a semi-permeable membrane, but it also keeps buffering the pH up towards neutral. So the paradox is we need this cyclical acid attack to create the fluorapatite veneer on the crystals. Now, one of the problems is if you've got a cariogenic biofilm and you also have highly substituted enamel in the erupting tooth, as the tooth is sitting underneath an operculum, it can decay before you even get to see the tooth. So if we look at the cross-section through a fissure, it's basically like it's sort of Coke bottle shaped. There's an organic plug in the entrance to the fissure. You can have at the entrance to the fissure, in the presence of low pH, you can have demineralization occurring here, or you can actually have developmental hypocalcific enamel. Now that's a bit of a problem because that's porous. So if you put a resin sealant in here, it can leak around underneath the seal that you've established. So acid can percolate in underneath here, and if that was a sealant instead of the organic plug, you end up with decay down, becoming established down in the walls of the fissure. So decay can begin way down in here, regardless of whether the presence of healthy mature enamel at the entrance. So you can end up with developmental dentine caries getting well established even before you get to see the tooth, because this could be happening underneath the operculum. So once we've got acid attack happening down here, you can actually have decay at the depth of that fissure. And if this is sound enamel here, you won't get the probe to stick. So the probe won't bind here unless you've got damaged enamel. So if you've got a fissure that's got something going on down in the depths of the fissure, you're not going to find it with the old classic probe. So this is an inversion of what we considered the normal process, which was decay starting in the entrance to the fissure. This is happening down in the depths of the fissure. And this is why we get people talking about fluoride bombs, because the enamel at the entrance is sound, but it's going wrong further down. Now, you can also have at the bottom of fissures, you can actually have openings where the enamel is not completely sealed. And so you can actually have fluid that's intraoral fluid can actually find its way down directly to the dentino enamel complex interface, and you can get decay happening down here, and there's absolutely nothing going wrong with the enamel at all. Now, there's only one way you're going to find this type of decay, and that's for the DIAGNodent. All the other sorts where there's demineralizing enamel occurring, you can use Caries Detection Dye. But these are all the various presentations that you can see when fissures begin to decay underneath an operculum. And this is the danger zone down in here in the depths of the fissure, because we cannot get at that with a probe. So if we look at what we can do with glass ionomer, glass ionomers create a chemical fusion to any dentinal or enamel structure. As long as there's mineral there, glass ionomer will stick to it. So it creates an acid-resistant ionic bond And we're calling this thing the chemical fusion zone. Now, if we go and look at sort of the microscopic level, there's, I don't know if we've got the slide of this. No, we didn't have, sorry. There is this layer that forms between the glass ionomer and the enamel or dentine that adds, it's not just a micromechanical bond, it's a chemical bond as well. And this study once again is another study. You can go back and look at these studies. They'll be in the slides when you want to review them. And there's evidence of ion exchange between affected and infected using, we've got half of my slide. How do I, okay, gotta do that. I've got heaps and heaps of people hiding my slides down the side and I'm not seeing what I've got written, sorry. So this paper was from here, and they were looking at the ion exchange between affected dentine and Fuji9, showing that this chemical fusion occurs. So what happens is you mix polyacrylic acid with the glass ionomer powder, and it begins to dissolve the outside of the particles, releasing the phosphate, the fluoride, and the metallic ions that are in there. Strontium is the usual one. And this becomes part of the gel matrix. When you apply this wet mix to dentine, the polyacrylic acid also begins to dissolve the calcium and phosphate out of the dentine. That then intermingles with the phosphates, fluoride, and the strontium from out of the glass ionomer, and you get this chemical fusion zone. That's a combination of the gel matrix contents and the calcium and phosphate out of the dentine, and you get this chemical fusion zone. Now, this is an SEM that Here produced using a cryovac stage, that's incredibly difficult SEM work, playing around with minus 120 degrees centigrade electron microscopes. But what he was able to show is this is enamel, this is glass ionomer, and he etched the surface with phosphoric acid, and then here's the interface, and you notice it didn't etch. It was acid resistant, and there's absolutely no resin in this at all. This is purely an ionic fusion that's created a material that's stronger than either enamel or glass ionomer in relation to what acid can do to it. So it's hypermineralized and acid resistant. Now here's an image I took using a different technique, but once again, you can see here's the enamel, here's the glass ionomer. It's been phosphoric acid etched, and the glass ionomer and enamel have etched, and the chemical fusion zone has remained stable. It didn't etch at all, so it was left as a ridge. Now, when you're using glass ionomers, you cannot place them on an uncleaned tooth surface because it will not bond to plaque, pellicle, or smear layer. So you have to clean uncut tooth surfaces with sodium bicarb prophylaxis or low pressure air-abrasion. Don't place glass ionomer directly on cut dentine or enamel because of the presence of smear layer. You want to remove that with polyacrylic acid or phosphoric acid, and we'll show you various techniques a little bit later. So if you're going to use polyacrylic acid, 10 to 20 seconds. If you're going to use phosphoric acid, particularly on dentine, it must not be on dentine for longer than 5 seconds, absolute max. Otherwise, you'll remove the mineral content and there's nothing for the glass ionomer to stick to. So it's much safer if you're working on dentine to use polyacrylic acid to remove the smear layer. Now, if you don't remove the smear layer, this is what it looks like. This is a cut dentine surface. This glass ionomer was placed onto the cut dentine surface, but we didn't use polyacrylic acid first. Then we sectioned the sample. Phosphoric acid etched it to remove the smear from the sectioning. And what it did is it also dissolved out the smear layer. And so here you can see the glass ionomer was not attached to the underlying dentine. It was attached to the smear layer that was on top of that. So what will happen in a situation like this is you will get hydraulic movement of the fluids between the glass ionomer and the underlying dentine. And you can actually end up with post-insertion sensitivity if you haven't removed the smear layer first. You will not get the chemical fusion occurring. So glass ionomer requires the presence of mineral to create the chemically fused seal. If there's no surface mineral available because you've used phosphoric acid on dentine, you won't get a bond at all. So it's quite safe to use phosphoric acid on enamel, but you've got to be very, very careful about it on dentine. Now, interestingly, there's also hydroxyapatite crystals that the glass ionomer can bond to within the collagen fibrils themselves. This is a really interesting paper, and the significance of this becomes more so once we start to look at the biomechanics of how a tooth functions, which we will be dealing with in the next seminar. But the collagen between the tubules, each of these collagen fibrils has 20 nanometer hydroxyapatite crystals within it. And what that does is it puts the collagen into tension, which keeps the core dentine of the whole tooth in compression. So it's a toughening mechanism. Also, if we look at this whole concept, if you go and bathe this collagen in phosphoric acid for 15 seconds, you strip out all of the mineral content within the collagen fibrils. So what's happened is the glass ionomer, which could bond to these collagen fibrils because of the presence of the hydroxyapatite crystals, can no longer do so if you've stripped all of the mineral out. So when we're using glass ionomers, one of the critical factors is it must be freshly mixed. It must be shiny when you place it. If you let it start to the matrix start to gel and you place it on a tooth, there's not enough free polyacrylic acid to start forming your chemical fusion zone. So it must be wet when you bond it. If it's lost its gloss, chuck it out, start again. So here's a chemical fusion zone that formed on dentine, and you can see it's quite deep, the chemical fusion zone that occurs here. And this is the same tooth. We put two mixes on the same tooth. One was a fresh, shiny mix. This one we allowed, so it was not shiny. And you can see, yeah, it adapted well to the tooth, but there's no chemical fusion zone. We've lost that acid resistance. Kiwi advertisers have a sixth sense of humor. Okay, so let's move on a bit. Auto-cure glass ionomer is a fissure sealant and as a micro-restorative instead of using resin as a fissure sealant, because I was getting really frustrated with the unpredictability of my fissure sealants, even though I thought I was doing it really, really well. So why do we want to use auto-cure glass ionomer for this? Because resin sealants have got a long history of success. And the interesting observation from several of my mentors, including Tim Rainey, was when you put them resin sealants on sound fissures, they work really, really well. But when you put them on fissures that have got carious enamel, hypercalcific enamel, or aprismatic enamel, the quality of the micromechanical bond can be seriously compromised. So this compromised bond leads to ongoing microleakage and subsequent failure. We've all seen failed sealants. We've all had them happen. But because we didn't have a viable alternative, we just kept on doing the same old because we didn't have any really good options. Oops, sorry, we're bumping the wrong button. So a lot of people actually gave up placing resin sealants because they weren't as predictable as they'd really like. So in the past, it's been used as glass ionomer has been used as a sealant, but a lot of the papers that are out there show very poor performance because of their poor abrasion resistance. And that's because they were using resin-modified glass ionomers, and resin-modified glass ionomers are absolutely hopeless in occlusal load situations. They wear away really, really quickly. I started using Fuji 9, which in the States now is known as Fuji Equia Forte, with incredible success. And this is based on the ability of glass ionomers to create both the micromechanical bond as well as the chemically fused seal to enamel. So if we go and look at some of these old papers, historically sealant retention was considered to be related to the application technique and occlusal forces. But this research showed that the retention of the sealant is related to the incidence of decay in that particular patient. In other words, the patients that needed the sealant protection the most to have the least likely success from long-term retention of their sealants because of the presence of damaged enamel when the sealants were placed. So they were being placed on undiagnosed early enamel fissure decay that is prevalent in high caries risk patients. They leaked through the unremoved carious enamel or the organic plug and consequently failed. So most fissure decay happens during the prolonged eruption phase, and in a high caries risk patient, this is even more significant. So once again, back to this white spot lesion. If you go and flood the surface with Caries Detection Dye, it will stain the white spot lesions, the damaged porous enamel that's leaking fluid. It could leak underneath your glass ionomer or resin sealant. If you place Caries Detection Dye in there, it will stain the damaged enamel. And if you go and look at Fusiyama's textbook, he actually states that Caries Detection Dye simply goes where there are voids within tooth structure. So it stains biofilm, it stains plaque, it stains smear layer, and it stains both dentine and enamel decay. So here's a resin sealant on a tooth that we took out, and it was obviously leaking and decaying. So we put some Caries Detection Dye on here, and you can actually see the damaged enamel all the way down to the dentine interface sitting underneath the resin sealant. That's just a time bomb waiting to go off. And here's another one. This resin sealant was placed over organic plug and organic matrix, and you can see underneath here we've got significant dentine decay, and that resin sealant is not preventing the progression of this decay process. I just call them custom fitted plaque applicators. And if you think at it from just a totally different perspective, if you had rusty steel with flaky paint on the top, in other words, that's your plaque and biofilm and this is your decay, would you just go and put paint straight over the top of that and expect it to stick? Of course we wouldn't. Well, what we need to do is make sure we do exactly the same thing when we're dealing with teeth. We need to get down to clean, sound, prismatic enamel before we place anything on it if you want it to stick properly. So if we go and look at one of the papers that Tim Rainey published, Caries Detection Dye in this paper was a reliable diagnostic tool for occlusal carious lesions. The ratio of occlusal grooves stained by dye to the underlying carious lesions was 1:1. There was 100% diagnostic. 75% of these lesions that were found with Caries Detection Dye were missed when they were examined with just a probe. So another thing is, if we start looking at the eruption phase for teeth, significantly more bacteria, including aciduric bacteria, lactobacilli, were isolated from newly erupted teeth and from teeth that have been erupted for over 12 months. In other words, when they're in this eruption phase, sitting underneath the operculum, they're in a lot of trouble, and you can get a lot of the acidogenic and aciduric phenotypes become seriously established. 80% of decay in teenagers is occurring in the occlusal fissures. So what we've got to do is get these fissures stabilized and safe. So this paper pointed out almost all molar occlusal caries is initiated in the long eruption phase of 12 to 18 months. It's interesting, if you have a look, you don't see a lot of fissure decay in premolars because they have a very short eruption phase in comparison to the molars. So it's when a tooth sitting here at this point in time, if you've got a patient with a diseased cariogenic biofilm, basically the bugs get in underneath the operculum and they're sitting there. They're not being removed. They're just doing the damage. So I've just photoshopped an operculum in on this because this tooth, look, when I first saw this patient, this tooth actually looked like this. Now you can see, now I apologize for the quality of some of these images, but I really like using them. These are scans of prints from over 25 years ago. This is when we were starting to work out what was going on here. We were using Air-abrasion and Caries Detection Dye to identify and diagnose what was going on in these fissures. So these images aren't particularly sharp, but I love using them because nothing's changed. So here we are, Caries Detection Dye on the fissures. We've started to open this up using micro air-abrasion. But if we had not dealt to this correctly and just dropped a sealant over that whole tooth, the sealant would have been missing when you saw the patient next visit. This is interesting. This is an interesting paper. 705 occlusal surfaces in 17-year-olds were followed for 6 years. A third of all sound occlusal surfaces developed a new radiolucency and over 70% of the existing radiolucencies progressed. A third of the teeth without symptoms of dentinal caries showed dentinal radiolucencies, and over 70% of the existing lesions showed progression. And this is the frightening bit, irrespective of the presence of the sealant. In other words, what they're saying is the sealants were leaking. So this is why they were getting a 70% failure rate underneath their sealants, is because they were putting them on over-damaged enamel. So I just keep asking all of my colleagues, do you guys see what I see? Here's a fissure sealant. That one's working. This one had been placed over what is obviously now a diseased fissure. Part of the sealant is still present, but we put Caries Detection Dye, and you see it's actually leaking in underneath the fissure. That's why this part of the sealant's already fallen off. Then we started opening it up using micro air-abrasion and more dye, and all that's happening here is that the dye is showing me the damaged enamel I need to remove before I can put another sealant back on this tooth. This is an interesting case. This mum had a very high dental IQ, and this youngster, she was 7 years old, and she'd had sealants placed by the dental therapist, and she noticed after 6 months that the back half of the sealant had disappeared off this tooth. So she brought this young lass in for me to have a look at and to pass comment on. Now, interestingly, this front half here is still present. So if we started taking all of the old sealant off, and you can see when we got there that there is absolutely no decay in this area, which is why the sealant was still bonded. Here, where all the decay is present, and we can see we've put Caries Detection Dye on here, and it's staining the walls of the fissures in here, showing that the walls of the actual fissures were demineralizing because of the presence of acid in the depths of the fissures, and the sealants just won't stick. And this is the glass ionomer sealant that we placed there, and that's still working 15 years later. Once again, we look at these two teeth here. You can see in here, you can see there's actually white lines within the fissure walls. So if we go and put some, well, this is now, once again, this is using the DIAGNodent. This had a reading of 45. Anything over 20, you got to start thinking serious about investigating. These two little pits here were giving a reading of 38. So we put Caries Detection Dye on here, and you can see how much damage there is within this fissure pattern. Anywhere that dye is staining, the enamel is porous. And we started opening this tooth up, putting Caries Detection Dye. You can see there's discrete points of decay. Now, it's interesting. The next seminar we're going to be doing will be looking at the micro-occlusal anatomy in enamel that helps protect teeth from stress fracturing and stuff. And we're tending to damage all of these structures. The comment I would make at this point, and I will actually be showing this tooth from a different perspective in the next lecture, but decay only happens between the support structures that stabilize the occlusal surface of the tooth. The strength within the occlusal enamel is not where we can get decay. It's between the decay, the areas that can decay, that help support what's known as the peripheral rim of enamel. So this is just to give you a quick heads up. There's a thing called the subocclusal oblique transverse ridge on lower molars. There's a suspensory web of enamel, and there is this structure here we call the peripheral rim, and it basically acts like a bicycle wheel. It supports the peripheral rim. So if you start cutting all of these support structures in the occlusal surface, you destabilize the tooth and set it up for long-term for fracture. So don't go randomly carving out the occlusal surfaces of teeth. We need to keep all of these structures, these support structures in place. See, if you have a look here, you can see, where's this tooth going to decay? It's going to decay there, there, in here, or in there. Maybe. It actually hasn't, because it's a 35-year-old patient, and those are just stained fissures. And here's another example of these cross support structures. Here's the peripheral rim of enamel, and you can see the support structures here are not wearing away. It's just the occlusal enamel between the support structures that's starting to fail. Right, now let's get back to the glass ionomer story. There's another material that GC produced called Fuji Triage, and we've been using that. It comes in pink or white. If I was concerned about the state of a fissure pattern in an erupting tooth, I would put the pink on, and it was a warning to me that I wanted to watch this tooth very closely, because I hadn't been able to, I was trying to actually get some of this glass ionomer on while the tooth was sitting underneath an operculum. But what it does is it creates a film that protects the immature surface enamel from plaque acid attack, at the same time becoming a source of fluoride ions to improve the production of hydroxyfluorapatite in the surface enamel. So it was designed as a fissure protection material, and it was designed to be used during the prolonged eruption phase when most occlusal caries becomes established. Now, resins are not indicated for surface protection because they stop the maturation of the underlying enamel, because there's no longer, because the glass ionomer acts as a semi-permeable membrane. Resin doesn't act as a semi-permeable membrane. So all that will happen is you will prevent the surface enamel from maturing from its carbonated state to a fluoridated apatite. And how have these Fuji triage restorations been performing? They've been going incredibly well. This one was done while the tooth was still half covered with an operculum. We got in underneath the operculum with phosphoric acid on a little microbrush and scrubbed the surface as clean as we could get it, and held the operculum up with a little flat-bladed instrument and literally just flowed the Fuji triage or Fuji 7 in underneath it and let it set. So here it was initially. And the tooth in front here has had Fuji 7 put on it, which is now Fuji Equia. But hello, I've got a double up of slides, sorry. So in the fissure enamel, there's ultrastructure that can contribute to sealant failure. If we go and look at the walls of a fissure, it's heavily lined with aprismatic enamel. Now, that's not actually something that resin bonds really, really well to. So here's the tooth surface, and you can see the plaque biofilm sitting on the surface here of the fissure enamel. Here's underlying prismatic enamel, and that's the aprismatic enamel. And it's at its thickest when the tooth first erupts. On the external surfaces, it slowly erodes away, but it never disappears out of the fissures. And it really challenges the bond in the depths of the fissures. So if we look here, even now, this is the fissure enamel with aprismatic enamel on it, and we etch that for 60 seconds, and it still doesn't etch very well. And once again, now this gives you more of an idea of what's going on. This is the underneath surface of a resin sealant that's been applied to a bevel margin and then enamel, aprismatic enamel that was sitting beside the bevel. There you can see this is the bond that we get to cut enamel when we've etched it with phosphoric acid for 30 seconds. And this is what you get to aprismatic enamel. That's nowhere near as strong a bond. And equally, if that is demineralized or hypercalcific, it will leak like a sieve. So if we take this, here's a white spot lesion within the fissure wall. So here's the fissure, here's the surface that's got biofilm on it. Here's the aprismatic enamel, and here's the white spot lesion sitting underneath. Now, if you have a fissure sealant on here that isn't completely sealed out to a very sound enamel surface, you will start to get fluid percolation underneath the resin sealant. The plaque acid will percolate through here, and this sealant will leak, and you will continue to get this development of decay underneath the resin sealant. Now, the glass ionomers have attributes that help address some of these problems. It will bond chemically to aprismatic enamel, prismatic enamel, hypocalcific enamel, and dentine. However, I would be very concerned about sticking it straight to hypocalcific enamel within the fissure pattern, because that can still leak underneath. The interface is only about 5 to 10 microns thick, and you can have demineralized or hypercalcific enamel that's full thickness of the whole enamel membrane. So glass ionomers will stick very well to aprismatic enamel. If we go and look at this chemical fusion zone, you can see, once again, you can see the acid resistant layer that's formed on the aprismatic enamel. So we get exactly the same interface that we get when we're bonding to prismatic enamel. So just to reiterate, you have to place this on clean enamel or dentine. You don't want any smear layer present. Now, as an aside, don't place autoclear glass ionomers on laser enamel. There's a subsurface disruption when you're using a hard tissue laser that extends about 30 microns into the tooth surface. You need to either scrape that, run a slow speed burr over it, or air-abrasion over a laser surface before you put any restorative on it. So if we look at a little bit more of this SEM work, just to have a better understanding of this interface, it's only using phosphoric acid is only valid on enamel, because if you over etch enamel, all you do is just simply expose more mineral. Whereas if you over etch dentine, you're going to remove all of the mineral and you're only going to have collagen left. So if you're going to use phosphoric acid on dentine, the maximum is 5 seconds. Otherwise, you're going to cause yourself all sorts of problems. So once again, here's this this interface. Now, how we did this was glass on enamel. We sectioned it and then etched it with phosphoric acid for 15 seconds. And then we placed a low viscosity resin over it, set the resin, then we dissolved all of the tooth structure and glass ionomer off. So what we're looking at is a resin impression of the interface. Because the problem when we're doing SEMs on glass ionomers is because they're water-based, you put them in a hard vacuum, they crack. Then everyone looks at the images and go, oh, why would I put a material on a tooth that looks like that? Well, the only time it becomes a problem is when your patient puts their head in a hard vacuum. So anyway, what we do to make this image a little bit more understandable is we digitally invert it. So now you can see the interface between the glass ionomer and the enamel, and you can see, much as this has been etched for 15 seconds with phosphoric acid, the glass ionomer chemical fusion zone is acid resistant. And if we go and look at it really closely, you can actually see this is the glass ionomer chemical fusion zone. This is the end of a single prism. So what you're looking at here is individual hydroxyapatite crystals within the prism, and you can see that these are incorporated within the chemical fusion zone from the glass ionomer. So not only do we get a chemical bond, we also get a micromechanical bond, which makes these things very, very difficult to remove. So once again, you can see in this one, you can see how the chemical fusion zone is incorporating the hydroxyapatite crystallites within within the end of a single prism within the chemical fusion zone. And we start looking through a whole lot of studies. This study suggests that etching enamel prior to the application enhances the bond of glass ionomer sealants to fissure enamel. Well, yes, I'd have to agree 100% with that one. We've been doing it for quite some years now. Micromechanical bonding may play a role in the mechanism of bonding glass ionomer to enamel. Well, those SEMs absolutely nail what they were commenting about in these papers. Now, on first reading, this next paper looks like it casts glass ionomer sealants in a negative light. And the reason was they were using resin-modified glass ionomers. And so as a result, they were wearing away, they were falling off because the material just wasn't designed for it. But interestingly, even though they were losing most of their glass ionomer sealants, none of those had any decay in them. And yet there was the resin sealant part of the study had a 5% incidence of decay underneath them. There was none underneath any of the glass ionomer sealants. So in the event of a glass ionomer breaking or wearing off the tooth, the acid-resistant chemical fusion zone is still left attached to the tooth. And this is probably why we're seeing this, even though they were using the wrong glass ionomer for this, we were seeing 100% caries resistance in the studies. And this is what, now this is an SEM of really, really deep dentine. We're within 1 millimeter of the pulp. So you can see how close the dentine tubules are together. Yet when we fractured this glass ionomer off, the chemical fusion zone was still adherent to that deep dentine. And here it is on shallow dentine. Once again, here's the chemical fusion zone. We fractured the glass ionomer off, but the chemical fusion zone is still adherent to the tooth structure. No one's actually been able to investigate the strength of this bond, because when you try and fracture glass ionomer off, it always fails above the chemical fusion zone. So no one's actually been able to work out what the strength of this bond is yet. So let's just look at a quick study I did in my practice. We did a retrospective look back in my practice, looking at how these things were working. So what the assessment criteria were Is the patient alive? Are they breathing? Yes, you're in the study if you've got a glass ionomer sealant. So whenever they came back for a checkup, if they had a glass ionomer sealant, they went into the study. So what did we do? We looked at the age, how old the restorations were, their physical status. Were they sound? Was there any marginal chipping? Were there any partially missing, or were they completely missing? Could you see any decay? Was there anything on the radiographs? And what were the DIAGNOdent readings in areas where there was a missing glass ionomer? So what did we get out of this? Or what I did, because I was looking at my own work, I photographed every restoration for independent assessment if anyone wanted to argue with what we were doing here. Out of 80 restorations that were ranging in age from 2 to 5 years, average of 3.1, 79 were sound, 1 was partially missing, all 80 were visually caries-free, none of the x-rays showed any decay, and the DIAGNOdent reading on the one that was missing part of the restoration, the DIAGNOdent reading was 5, which is basically the reading for natural enamel. So we had a 99.25% retention rate and 100% caries control. Here's the partially missing restoration, and that was the DIAGNOdent reading of 5. So I wasn't concerned about it at all. But this is what these restorations look like. And they just keep on keeping on. They've been incredibly predictable. Now, getting back to this one that we had the Fuji triage in, we followed these ones. This was Fuji 9 at 5 years and the Fuji 7 at 3. Here it is 5 years later. Fuji, that's at 10 years, and the Fuji 7 at 8 years. Sure, they're wearing away a little bit, but that's of no major concern because it's within the depths of the fissure pattern. And that's where you want your protection. The fact that it's worn off a little bit away from the fissures is totally inconsequential. And here's the Fuji 9 at 11 years and the Fuji 7 at 9 years. And they just keep on going. You'd never get me to change back. Sorry, you'd never get me to change back to resin sealants, having seen this now. My mentor, Tim Rainey, who put me onto this in the early days, he was actually using a material from GIC that was a glass ionomer that had amalgam particles in it. And so it was black. It looked ugly, but he was putting that into fissures and they were lasting. In fact, it got to the point he was quite prepared to offer a lifetime warranty on teeth that erupted under his supervision. And as long as they came back every year for a checkup, he'd offer a guarantee on that tooth that it wouldn't decay. Now, how do you get a really good surface to bond to? The very best is air-abrasion. If we look at this is just using SE bond, which is a without any enamel etching. So you see the enamel bond is particularly strong, but the dentine bond is amazing. If you phosphoric acid etch the surface, you get a stronger bond than you're getting here. Just a little device, this is a total aside. If you are playing around with air-abrasion and you're trying to clean different pieces, articles, or crown or something, this is the end of a 1.5 litre Coke bottle that we've made a little attachment that goes onto the suction so that I can clean any of these pieces without it making a mess in the surgery. But I've been using, I was using the Creative Mac 5 Plus, which had some beautiful fine tips. Eventually that died after 16 years. So I went to the Crystal Mark unit, which has the same sorts of tips. So you're able to use very fine air-abrasion. Nothing, please don't use any of the lab ones with the big bottle on the end. They just make a mess. The bore is far too wide. You've got no precision, no control, and you'll give up on air-abrasion the first time you ever try and use one. Now, the other thing you need to do if you're going to be using air-abrasion, which I highly recommend, is to get a couple of these mirrors from Crystal Mark. They've got a sapphire crystal face on them, and as long as you don't aim the air-abrasion beam at them, these things have been running up. The oldest one I had is 15 years old and it's still totally usable. If you try and use disposable mirrors, within about 5 seconds when you're working in the upper arch, you can't see anymore because the mirror's fogged. You've got to be using something that makes your life easy. And these are the mirrors that do it. And this is the air-abrasion unit I had to swap out to, the Crystal Mark. I think that price is a little bit out of date now, but this is an old slide that's been sitting around for a bit, or the little Prep Start. But you've got to be able to you need a fine tip, you need to be able to control the pressure and the powder flow rate, because as soon as you do that, you've got control and you can see what you're doing. So here's a video of me doing a little glass ionomer restoration? Well, first of all, but if you look at this tooth, you can see that there's demineralization occurring within the fissure pattern. Now that we've sort of drawn your eye to it, we go and put Caries Detection Dye on here. This will all stain bright red. Now we're going to get in with a very fine air-abrasion tip and start opening up the fissure pattern. Now, one mistake people make with air-abrasion is they tend to paint like we do with a high-speed drill. It will not cut. You've got to put the beam there and you've got to let it focus and let it find its way. And so you need to move very, very slowly. So here's the air-abrasion. Once we stained it up with dye, you can see all the damaged fissure enamel. Very easy to see now. Now, the interesting thing when you're using air-abrasion is it targets the damaged tooth structure first because it's soft. So the aluminium oxide particles will selectively cut damaged enamel first. But see how slow I'm moving the tip? I'm not waving it around. You point it to where you want it to cut. Because remember, this is an end cutting device. So visualize you've got a burr that's only got diamond on the end. Now, this little fissure here, we start cutting along the length of the fissure, and you can see it's already removed the dye that was in there, but you can still see the demineralized enamel. It's white. But if we tip it over, you can see the air-abrasion was actually cutting sideways. It actually cut out into the decay that was happening in the wall of the fissure. So that decay wasn't at the bottom of the fissure, it was happening in the sides of the fissure. So this tooth has been cleaned and prepared. And so what we do, or both of these have, so they're now being etched with phosphoric acid. If that so happened to go all the way through to dentine, what you would do is not put the phosphoric acid into the bottom of the cavity until right at the very end, and you can just pop the bubble and let the phosphoric acid touch the dentine for about 3 or 4 seconds and then wash it all off. Then it's simply a matter of a fresh mix of Fuji Equia, put it into the depths of the fissure, and it's like grouting. You want to push the glass ionomer ahead of the tip so it flows along the fissure pattern, and grossly overextend where you want the glass ionomer to go. You want the glass ionomer to be applied well beyond where you visualize it actually finishing. Then you get a ball burnisher dipped in G-Coat Plus, which is part of the Equia system. And you basically go into the center of the glass ionomer mass, and you just, the G-Coat is acting as a lubricant, and it lets you push the excess glass ionomer off the tooth. The second thing it does is, because it's it's an acidulated resin, when you hit it with a curing light, it's going to seal the surface of the glass ionomer, because glass ionomers really do like to mature in the absence of water, because during the first 24 hours, it tends to weaken the surface of the glass ionomer if it's wet, whereas if you've got it sealed with a resin, the glass ionomer will mature to its maximum strength. And when you get really good at this and you get the hang of picking the gel phase of the glass ionomer, once you've grouted it through all the fissure pattern, if you get to the center and you start working out with a ball burnisher dipped in G-Coat Plus, you end up creating this donut of glass ionomer that you can just get your probe underneath and just flick off. Then you hit it all with a curing light, and that sets the G-Coat Plus and protects the underlying glass ionomer as it matures. So just in summary, etch enamel with phosphoric acid, or condition the dentine surface for 10% polyacrylic acid, or only 5 seconds if you're using phosphoric acid. Rinse, gently dry, inject freshly mixed glass ionomer. Now, does that sound too difficult? I can do a quadrant of 4 teeth, in other words, all the premolars and molars. Restoring them, I can restore them in about 3 minutes using this technique with 1 capsule of glass ionomer. Now, just moving on just for a second. So that's the basic presentation. What I want to do is just give you a heads up on what we'll be doing on Saturday, the 27th at the same time. We'll be looking at the fracture modes of teeth and how this misdiagnosis can lead to incorrect treatment and failed treatment outcomes. If you think about it, to pay to see this next seminar, I think it's going to be about $70 or something. I'm not quite sure. You've only got to have one treatment failure because you did something wrong with a fractured tooth, and it's going to cost you $400 or $500 to fix that, and you're going to have an unhappy patient. Or you learn about what we're going to be showing you here and avoid these problems in the future. So what would you be learning out of this? You'll learn how teeth function at the biomechanical level, what we do to upset Mother Nature's design, the 6 dental fracture types and how they occur, how to treat these different fracture modalities, and then the various restorative techniques to help recreate Mother Nature's biomechanical stability. So believe it or not, all of these teeth here, all of the state that these teeth are all in, with these ones have got a fracture that's occurring between the peripheral rim and occlusal enamel. This one is known as occlusal effect decay. This one we've seen all the time, cusps falling off. All of these are happening because of what dentists are doing to teeth. So you can actually call this iatrogenic damage. Much as we're trying to fix teeth for our patients because they've got a diseased biofilm, and that's the other thing the beginning of this lecture was all about, is let's not let the patients get their teeth to this state. Let's see if we can keep them in a stable state. And so the 6 fracture modes, occlusal effect caries, there's 2 types of those: vertical fractures, mesiodistal fractures, oblique cusp fractures. There's a new concept I'm discussing called Poisson effect fracturing, and then we just have straight trauma. So at this point in time, I think I've reached the end of the lecture. So thank you very much for your attention, everybody, and I hope you found this of some help.
All right, that was great. I hope everyone enjoyed it. Thank you, Dr. Milicich. How are you?
A pleasure.
I think you did wonderful. And thanks to I want to say thank you to all of our board members for showing up today. Hey, Dr. Milicich, would you mind stopping share of your screen there?
Yeah, I'm trying to. I got. Here we go. Everyone's thumbnails was covering half side of my slide, so I shoved everyone off the screen at the top, and I lost my stop share button.
I know we all need bigger monitors now, right?
Oh yeah, we need. I'm on a laptop because my laptop's actually higher end than my desktop, so it's got a better camera and everything.
So here's your coupon code. Write this down, save your $10, go to this web URL right here, and you should be good to go for 2 weeks. Well, I'm going to keep that coupon code active for the next, till the end of the night. So that's it for my little kind of covering of everything. If anybody has any questions, just go ahead and put it in the chat to Matthew Miller, and I will answer those. I'm going to be sticking around, but I'm going to hand it over now to Dr. Lazar and Dr. Milicich. Once again, thank you. Great job, Dr. Milicich. You killed it tonight. So thank you for your time.
All right. That was fantastic. I appreciate this amazing lecture. I appreciate what you've just said, Matt, and I appreciate everyone being a part of this this webinar. Yes, we have an amazing group of people here. We have an amazing group of individuals who are members, so I do encourage membership. There's so many benefits to membership. It's a nominal fee to be a part of our academy, and we have a wonderful group of advisors, of lecturers, of people who just want to share the information and help each other become better clinicians and better people. It's just a really amazing group. I also want to urge everyone to listen to the Dental Digest podcast. They are incredible, and to be a part of all of our webinars here. So yes, let's start and ask Dr. Milicich a few questions. We have a number of them coming in.
I've noticed one here that I'm itching to answer.
Yeah, etching,
not itching.
Etching to answer.
It's from Keith Hollander.
So speaking of etching, all right. So let's ask a few questions. So first, a question came in saying, if a child has decay in the primary dentition, is it better to go ahead and seal the erupting molars with glass ionomer, whether there are caries or not?
Well, absolutely, because if the kid has already got decay, you know they have got a pathogenic biofilm. So that biofilm is going to establish, and if you remember one of the papers I talked about, while a tooth is erupting, the actual biofilm that establishes underneath the operculum is actually more aggressive than one that's actually exposed to the open oral environment. So yeah, get those teeth covered in Fuji Triage Fuji 7 as soon as you can see them. clean them and seal them.
Okay, there are a lot of questions about the aquea and triage, so there might be some repetition here since the questions are keep coming in. One question is, why use the aquea versus the triage for sealants? Does it penetrate as well as the triage? And also, what about Fuji 7 for sealants? Is it not as abrasion resistant as the Fuji 9?
Believe it or not, both of them work equally well. Fuji Triage, Fuji 7, it's the same material. It's just GC have this nasty habit of calling them different things around the planet, which makes lecturing really difficult because wherever you go, you've got to make sure you're using the right phrase for that country. Because I'm talking to the world, I've got to use both. But in all honesty, if someone said, sorry, you can't have Fuji Aquea, you've only got Fuji 7 for your surface protection and sealants, I would not be concerned at all. But when you start doing things like sandwich restorations and that sort of thing, you need a material that's physically quite strong, which is where Fuji Aquea comes in. Fuji 7 is very abrasion resistant. It doesn't misbehave like the Fuji 2LC, the resin modified glass ionomers. So that's the big mistake, is because it's quick and easy to use a light cured glass ionomer. That's great, but you just can't use them as a Fissure protection technique because they just don't hang around.
Okay.
Now, there's an interesting question I'm looking at here, which I'd like to just chip in on from Keith Hollander. Is saliva always a supersaturated calcium phosphate environment? The reason this pushes my button a little bit is when I graduated from dental school, I visualized saliva was actually made up of calcium and phosphate ions that were then, when they got in the presence of the tooth, you would get precipitation of calcium phosphate. Well, in actual fact, if you think this through, saliva is a neutral pH. Now, calcium and phosphate cannot dissociate until they're in a pH of 5.5 or less. So if your saliva is neutral pH, the calcium and phosphate in your saliva is primarily nanohydroxyapatite crystallites of about 20 nanometers. And it's when they when they're released into the mouth and there's an acidic environment that the calcium and phosphate will dissolve out of these nanoparticulate crystals. And so when you start looking at how remineralization occurs when crystal interfaces lock onto one another. It's a fascinating the whole process of how crystals develop. But yeah, my original visualization of saliva just being calcium and phosphate ions was totally wrong.
Someone else just asked, do you have any thoughts on SE bond followed by a coat of very low viscosity flowable or an Optibond FL adhesive bottle as a sealant? Would the acid-base resistance zone and chemical bond of SE bond have a similar effect as the glass ionomer, but with the strength of a resin?
I've never sort of done enough to look back and have a look at do retrospective study, but the reality is resins are resins. If you're looking at the bond of a resin to enamel, it is about 5 microns deep, regardless of whether you're using SE bond or you're using a total etch system, whatever. And a lot of this demineralization can be full thickness in the enamel, so it's going to leak underneath. So if you were applying resin to sound enamel, yes, that's going to work. If you're applying resin to enamel that's sort of slightly damaged and you didn't quite remove it all, glass ionomer is going to have a lot better chance of protecting that tooth because of its continual fluoride release compared to a resin.
All right, on the follow-up to that, there are a number of patients who are holistic minded and are concerned about fluoride. How do you explain to them about the use of fluoride with these glass ionomer sealants?
Well, I explained in New Zealand, we have an issue because we're basically a volcanic country. I tell them it's a naturally occurring water-soluble mineral that in New Zealand has been washed right out of our soil, along with selenium and cobalt. Like in the high country in New Zealand, we have a serious problem with what's called bush sickness in cows because of there's no cobalt. It's all been washed out by the rain. So is our fluoride. And I say, look, if you were in the right parts of the world where this occurs naturally, you would have better teeth than you have in New Zealand. So we have to put the fluoride back in. If you don't want fluoride, that's fine. That's your choice. But I want you to understand that if we don't use these materials, it's a poor second option. But I'll still let them choose. I'll put a resin sealant in if they say I don't want anything that's got fluoride in it. That's fine. That's their choice.
Right.
But I make sure they understand what their decision is, the significance of their decision before they finally say yes or no.
And I would imagine that once it's said, it shouldn't really escape too much. I mean, it's kind of like an optibondifilia. You have fluoride as a release inside there as well.
Well, the cool thing with glass ionomer is it recharges. So if you're using a fluoridated toothpaste, that constantly recharges the glass ionomer. If you're in a fluoridated water area, that recharges the glass ionomer as well. It becomes a soak. If you're in non-fluoridated areas, well, yeah, it will eventually sort of, that part of the process won't work anymore. But fluoride's only part of the equation. The biggest thing is to try and get a healthy biofilm back into place for the patients. That's the primary push is, how do you train a biofilm back to health? And it takes 6 months. You can't force Mother Nature. And we know that we can't brush and floss decay away. You've got patients that have got the most perfect oral hygiene and they still grow cavities. You've got to teach the biofilm how to behave. So you've got to let the healthy commensals re-establish. And the only way you do that is by elevating pH.
So what things would you suggest to help get that biofilm back to health, or what things would you avoid necessarily? Would you, for example, would you avoid sodas and things that obviously have a lower pH? There's certain things you would just avoid, or maybe certain things you might do, like chewing, a sugar-free gum to help raise the pH. Well, what things would you do and not do?
Yeah, well, that's all of that. The Caries-free system itself is really designed to keep the pH elevated for a long period of time, for months at a time. Patients that misbehave and drink a lot of acidic drinks and all that sort of stuff, all they're doing is retuning the biofilm. They're basically giving themselves a mouthwash that kills off all the healthy commensals that don't like a low pH environment. So they really just, it's just the vicious roundabout goes on and on and on. So one of the things for people that don't want to get involved with the Caries-free products or that sort of thing is I just tell them, look, get a little container with some baking soda in your bathroom, and when you put your toothpaste on your brush, then dip it in the baking soda and use that to clean your teeth, because that's going to give you an elevated pH every time you clean your teeth, at least. If you want to be silly and use a mouthwash, you can make your own just by putting some baking soda in ordinary water and sipping on that. Now,
Pascal asked a question. What about using a diluted sodium hypochlorite rinse? Like a 0.25% diluted bleach rinse to use for plaque control, as opposed to the Caries-free. How does that compare to the Caries-free?
Well, I personally didn't try to gazump the Caries-free products. There was a lot of research went into those, and as a consequence, I just used them. I didn't even try to make up something myself. And if you've ever tasted the treatment rinse, which is basically sodium hypochlorite, it's got flavor in it, but it can be a bit challenging for people for a little bit till they get the hang of it. But I just stuck with the Caries-free products because they were simple to use.
And I guess in the same vein with the sodium hypochlorite, would you ever consider using the sodium hypochlorite to treat the dentin before placing the glass ionomer to help remove the smear layer?
No, I don't, because to remove a smear layer, you need a low pH, not a high pH. And that's sodium hypochlorite's got a pH of about 10.5, I think, or 11.
Okay.
So it's not going to do anything to the smear layer whatsoever. The best thing to remove smear layer is low pressure micro air-abrasion. That's the ultimate way to remove smear layer from a tooth structure. It's interesting, the Caries-free products also, their maintenance rinse and that, they've actually gone and put in, because they understand now what the makeup of saliva is. In other words, we've got this nanoparticulate hydroxyapatite crystals within our saliva. They're actually putting that into their rinse as well. So it's becoming more like an artificial elevated pH saliva.
Yeah, no, I used to use that Caries-free rinse a while back. For me, it was hard to get people to be disciplined and to stay with that whole system. But for people who did, it worked very well.
Exactly. Well, that's the trouble, is it takes a minimum of 6 months to train a biofilm back to health. You can't beat a biofilm into any shape whatsoever. It's going to go where you guide it, but it's not going to go there in a hurry.
Yeah. Would you use air-abrasion without using the acid etch for the glass hammer sealants?
You could do, but you won't get as good a micromechanical bond. You'll get the chemical fusion zone, but you won't get the micromechanical bond you get when you etch the when you pre-etch the enamel with phosphoric acid. So you'll still get a good bond, but you won't get the ultimate bond. And the goal is always aim for the stars, because if you hit the moon, that's fine, but you don't want to sort of not get the best you can possibly get out of the whole system just by trying to take a quick shortcut.
And I heard you say before you like the crystal mark air-abrasion system. Is that one that you find works well in most people's hands?
Yeah. Well, I started out with the Creative Mac 5 Plus. That worked for 16 years. And the only reason I had to replace it was the computer chip packed up. And where do you get a 16-year-old computer system rehashed? Couldn't find anyone that even knew anything about it. So the interesting, if you look at the generator in the crystal mark unit, it was the same one that was in the Creative Mac 5 Plus, and I got 16 years out of that. And it was, I mean, the actual air-abrasion side of it was still trucking on as good as the day I first started using it. And so I switched over to the crystal mark unit, and that's a very, very easy unit to use. It's simple. You can adjust your powder flow and your pressure, and so you don't make a huge mess. Don't be tempted to use the units that have got the glass bulb on the end that you'd use out in the lab, because the bore on the tip on those is enormous. It'd be like shooting a sparrow with a shotgun.
And a separate side question. I know you've published quite a few articles, many of which that the science of biomedical dentistry is based on. Of the articles that you've published, which of those are you most proud of, and why?
Well, the first one I published with Tim Rainey on the stress distribution in teeth back in 2000. That was one of my favorite papers. And the other one I published, I think it was 2017, on the compression dome concept and how to, I forget the name of the paper now. It was, I'm having a brain fade. But yeah, it basically describes the contours you need to do an adhesive ceramic onlay, and why you should be doing adhesive ceramic onlays and not doing full crowns. And that was published through the AGD, Academy of General Dentistry paper.
Yeah, there's a little preview for everyone who's going to be joining us in a couple of weeks. That compression dome theory that he's going to be talking about in a couple of weeks. That I remember hearing that back in 2015, and that stood with me. That leaves a real imprint on the way you practice and the way you perceive dentistry. So definitely, sign up and be there for that. That's a fascinating talk. And he's going to talk about that, not only that, but also the ways teeth fracture and understanding that. It's going to be an amazing talk. So definitely mark your calendars for a couple of weeks from now, February 27th. Another question to ask here is, so someone asks, what about the unreliable dental sealants are most likely, this is more of a statement than your thoughts. The unreliable dental resin sealants are most likely related to poor moisture control, not the quality of the bonding substrate. What are your thoughts on that comment?
Well, I was using all sorts of isolation techniques for using resin sealants, from rubber dam to isolate, all sorts of different gizmos. You saw one where I was using air-abrasion. It was a U-shaped plastic tube, was connected up to high volume suction with little foam pads and a tooth and a mouth prop, all sorts of things. I could put resin sealants on teeth and think, yes, I've absolutely nailed this. And they were all done at the same time in perfect moisture control. And the patient had come back a year later and 2 of them are missing. And when I understood what was going on and then reinvestigated those fissures using Caries Detection Dye and Air-abrasion, every one of them had missed decay in the enamel. Every one of them. So it wasn't moisture control. It was the substrate was not good enough to get a good quality seal. So then the sealant just let go.
Would you consider using these the glass ionomer type sealants or glass ionomer restorations on kids whose teeth are have a lack of enamel? hyperformation of the enamel.
So you've got a melogenesis imperfecta and all that sort of, to get the kids sort of through the real difficult phase, just to cover them with glass ionomer, you're not doing any harm whatsoever. There was an interesting case, one of the local oral surgeons, his son had a seriously hypocalcific first molar. Now we kept that tooth going because the enamel was literally flaking off it. We just kept that tooth going by continually, every year we saw him, we renewed the glass ionomer coating on it, and we got him through to an age where his second molar was starting to develop well. So, and then we took the first molar out, but we actually maintained that tooth without having to do any restoration on it, even though it was seriously hypocalcific enamel. It just helped the tooth survive till we were able to do something better. And it could have been a crown on the tooth, but we decided it was actually, in that case, it was better to take the first molar out, let the second molar and third molars drift forward and fill in the space. And it worked a treat.
Any tricks or suggestions to being able to protect the fissures of the teeth where the tooth is mostly still covered by the operculum? I know you're talking about the triage.
That's not easy. The ultimate way to do it is to, if you've got a hard tissue laser, you just cut the operculum off and then deal to it. Because if you use it, if you've got a way of making sure the tissue's not bleeding and that, then you can get it isolated and sealed. But the other trick is just do the best you can. Just get a flat bladed instrument and just hold the operculum up and get under it with a little wee micro brush to scrub some phosphoric acid or polyacrylic, just polyacrylic acid's fine, onto the enamel surface, and try and use the microbrush as a sort of toothbrush to clean the plaque off, and then flood underneath there with Fuji triage and just let it set. And then when the tooth's erupted, that's why I use the pink. I use the pink whenever I use that trick underneath the operculum. And that was just a heads up that I'm not quite sure how stable this is going to be, but 99.9% of them never needed touching. We got the sealant on and it protected the tooth, and the tooth erupted without any decay developing in the fissures.
If you have a tooth that you use that Fuji 7, obviously it's more of an orange colored, it's not as aesthetic, and the kids later on gets a little bit older and says, I don't like that orange look, can you change it over? Would you be hesitant to, for any reason, because it's already sealed and doing its thing there, or would you just clean it out and start again?
Yeah, if they were fussing about it, I'd pick up an Air-abrasion, because you don't need local anesthetic for this sort of stuff. You pick up your Air-abrasion unit, 30 seconds later, that old sealant's gone, bit of phosphoric acid and the new sealant on, and 5 minutes later, you've stopped them complaining.
Nice. Are you using helium in combination with the compressed air from your crystal morgue?
No, because they're using the helium if you want to use the Air-abrasion for fast cutting. The last thing I want to do in dentistry when I'm practicing minimally invasive dentistry is to be cutting fast. And so I tend to be working mostly when I'm doing these sealants and stuff, I'm working at sort of 40, 50 PSI, and I don't need aggressive cutting. The helium does improve the cutting rate quite significantly. But personally, I didn't get involved with it because I'd never felt the need for speed, unless I'm driving.
If you're preparing a fissure with air-abrasion or conservatively with a burr, how does the composite seal compare when you seal that with the resin versus the glass ionomer? If you're get a really nice clean with the air-abrasion or with the burr?
Well, you get a better surface. You definitely get a better surface with air-abrasion compared to a burr, particularly on dentine. On enamel, when you're phosphoric acid etching, it doesn't really matter how you prepare the enamel surface. But if you go and look at how good self-etching systems bond to air-abraded dentine as opposed to burr-cut dentine, the air-abraded dentine, I put that slide in the presentation so you can go back and review it. But air-abraded dentine is the best bond that we have got with all the self-etching systems. And you can say that glass ionomer is a self-etching system.
Do you recommend the air-abrasion over using a laser?
Yes, definitely. Lasers are great. I could not have practiced without my hard tissue laser, I+ and all the others I had. They were just amazing devices. But I did an enormous amount of research on tooth ultrastructure when it's been lased, and there is a subsurface disruption. When you think about a laser, the laser pulse hits a tooth. The surface temperature is about 400 C. when you start to get ablation on dentine. Well, what temperature do you cook your steak at? Because half of that dentine is just collagen, and what you end up doing is denaturing the collagen. So you actually ruin your bond if you're doing total etch preceded with laser. So what you've got to do is actually scrape the surface clean, or you run a slow speed burr over it, or the ultimate is just clean it up afterwards with air-abrasion.
Makes sense. All right, so what about bonding the glass ionomer to a resin or a bonding resin, like a super closed sandwich technique? Is it better to put the glass ionomer on dentin or put adhesive before that?
No, if you're using glass ionomer as a base, it has to go onto clean tooth surface. If the moment you put resin in there, you've basically killed the glass ionomer chemical fusion zone, because it can't form, because it'd be a little bit like if you were putting resin on there and you painted oil on the tooth first and then you tried to get your bond to establish. Well, if you put resin on the tooth, the glass ionomer isn't going to react with the tooth at all. So I use Fuji 9 as a base, Fuji Triage sometimes as well, or the Equia, and put that into as basically a disconnector. It's what if you follow Dave Ellerman's teachings on using fiber ribbon as a decoupler to protect your bond against shrinkage of overlying composite, glass ionomer Fuji 9 will do exactly the same thing for you as well.
Okay. Now, if you so demineralize like the white spots on people's teeth, they feel pretty hard. They're not staining with any red dye, but they're just there's unsightly white spots or possibly things that you might become something. How would you treat that? Would you treat it? Would you do anything to prevent that enamel from demineralizing further?
Yeah, well, if you can see it, you talk about smooth surface white spot, as opposed to in the depths of a fissure where you can't remove the plaque and you can't see it, but a DIAGNodent will see it. But if it's on a smooth surface and it doesn't stain with Caries Detection Dye, it's probably already remineralized, and don't do anything to it. Leave it alone. If anything, just put some fluoride gel on it or something, or you could put a thin layer of Fuji Triage white over the top of it to help remineralize the surface even deeper. But if it won't pick up dye, don't touch it, unless the patient doesn't like the look of it, if it's become a really dark stain on a front tooth or something.
Okay. Someone's asking if I have pinpoints of unnoticed decay at the depth of a fissure, will the glass ionomer arrest it?
You will have certainly removed the biological burden out of the fissure with your air-abrasion first. If you miss some little wee side, because it's funny when you watch how these develop, there's little tunnels that run sideways out of the fissures. I think once you get glass ionomer over the top of those, there's no large volumes of bacteria in there. And if the surrounding enamel is actually clean, so you get a really, really good seal, I think that will actually stop those little pinpoints from developing into anything, as long as you've got a good peripheral seal. So if you go back and look at Fairhurst's work, where they were actually bonding amalgam into teeth, they were cutting open the occlusal surface of teeth with identified dentine decay. But if you go and look at that study very carefully, they got success when they created a full 45-degree bevel onto sound enamel, and they bonded the amalgams in. So they actually created a seal. And that was why they were able to have some success with arresting deep decay. It was all about the seal.
Someone else is asking about, I guess, the crystal mark, saying how messy is it? Like how do you keep it so it doesn't create too much of a mess and aggravate the patient and get all over the place? So what do you recommend?
It never aggravates the patient because, one, they're not drowning for a start. The thing that if you're not using rubber dam, the first thing that patients don't like is all the water gathering at the back of their throat. So there's two parts to managing air-abrasion. You've got to get your assistant trained to look at where you're pointing the tip, because I've got this background behind you. You're pointing the tip, and then you get the reflection. So it's like squirting water at a hard surface. The water hits the surface and bounces off. If you can get your assistant to watch where you're pointing the tip, and she comes around and has the suction catching the reflection beam, she gets about 95% of the powder to start with. But they have to be awake. You don't want them just sitting there with the suction plugged into the patient's mouth while they're reading their phone. They've got to be actually working with you. And the other thing is with the crystal mark unit, you can drop the powder flow rate way down and the air pressure. You can vary the air pressure. So basically doesn't make it, I don't call it a mess at all. It's no, I'd sooner have that hanging around than all the amalgam dust we have cruising around when we're cutting out old amalgams.
I have another question here. Someone just asked, do you treat every infiltrated caries pit and fissure, or do you only treat them when they become cavitated?
I seal all fissures that it's interesting. If you look at teeth when they erupt, you could look at them. At some of them you look at and you know these are never ever going to decay. They've got beautifully, Mother Nature basically sealed the whole fissure pattern up. They're almost amorphous. Sealants work on those really well because you're sticking to lovely sound enamel. But all of the others, I will clean this. I mean, it's so easy. You clean the surface and put a film of glass ionomer over there, and pretty much that's the last thing you have to do to the teeth.
Okay. Trying to see if any more questions are coming in here. I'm thinking maybe we should just open it up to just an open discussion now at this point. Graeme, I'd like to thank you so much, Dr. Milicich, for this amazing talk today, and for just sharing, just for being here for us always, and for sharing. I think we should just open this thing up. If anyone has any questions, if you want to hang around, you're welcome to. I mean, you got to just watch this again, and just man, people who signed up, can they see this again for a period of time? There's so much great information here.
Well, no, that's it. It's now or never. No, what's really exciting is this is going to be on our ABD website, and we're going to be, since it's one of our free videos, we're going to be putting it on there, and also on our YouTube channel. So if you haven't gone to our YouTube channel, I'm going to make sure that I put more and more video content and case studies from some of our board members. I'm talking to you, Dr. Lazar, about giving us some of those fancy Manhattan case studies through. We're going to be making some really great high quality content videos, putting them on our YouTube channel. So please subscribe. And that's where you'll find this webinar as well. I'm going to hopefully get it up there within the next 24 to 48 hours. And I have gotten some emails from some people asking about the recording. So I will, if you registered for this webinar, I will be sending out a link to everyone so they can get access to it. And please do us a favor and support us by joining us in a couple of weeks. I know Dr. Milicich has put a ton of work and into this upcoming webinar. It's going to be an excellent show. I think someone had raised their hand too and had a question. So who was that?
Waving his hand around?
This one was, yeah. If anyone has any questions or wishes to unmute, now's the time. It's just kind of a free-for-all to say hello. I know, Dr. Bertolotti, we want you to unmute yourself. We want to hear from you a little bit. And thank you for attending, everyone. I appreciate it.
Great. Really
yeah,
good.
This has been another great session from Graeme. Now, I've heard him probably more than anybody else at this meeting, because I've sponsored him, 5 or 6 times, Graeme, maybe more than that. But I never get tired of hearing it. I always pick up something every darn time. And Graeme, I have another couple ideas I'm going to run by you next time we talk.
Right. Yep. I'm on.
About today. So I recommend everybody go to that seminar next time, because I've heard some of those things he's going to talk about, but probably not all of them, because he keeps evolving these things. It's fantastic, Graeme. You're the best. I'm telling you. You got more attention from me than anybody else on Fusayama. Okay.
I'm gonna ask you officially in front of everybody, and Ray, I'm back directing the acidic program at Loma Linda for the D4s now, spring quarter. So there's my invite. I want each of you to lecture Zoom this year. It's perfect.
Yeah.
So yeah, I can do that for you. That's not a problem.
Graeme?
Yep.
You're on. Ray, you'll do it. Ray, you've done it. How many times?
My hearing aids, sometimes I don't hear everything real good, Rich.
I said you've done the course how many times now for me, Ray?
No, I'm listening with my hearing aids, and I'm not doing very well. I should have put
That's all right.
computer.
And then The other one I'm gonna hit up is Pascal, but he told me I've got to call his dean.
Yeah, I saw Pascal had a couple of interesting questions there, so he's listening carefully. Of course, I listened to him very carefully too.
Did I ask
Yeah.
Pascal's questions out of interest?
Yeah.
Hello.
Yeah. Hey, Pascal, how are you? Thanks for joining us.
So much
Hi.
honored.
Let me switch. Voila.
There he is.
Voila,
Yeah.
there he is.
That's
There he
nice. Good to see you.
Thank you, Graeme. I was a little bit traveling around the house with my computer. That's why my camera was not on, and there's a lot going on here in America, right?
Yeah. You guys have got a sort of real handful with the old COVID thing under your belts as well.
Yeah. Political, health, everything. Yeah. So you said that I know maybe everything. That's not true. I loved your presentation. I really I was following very carefully. I had a few things that I maybe got wrong, like the one about the use of sodium hypochlorite to condition the dentin. It was my understanding that, when I was a student, I remember we were taught very clearly that exactly what you said. Of course, the ionomer has to interact with the calcium in dentin. And so using an acid has never been really a good idea, in my opinion, because your acid removes calcium from dentin. And when you said 5 seconds with phosphoric acid, why 5, not 10? Why not 1, 3 seconds, 2 seconds? How do you know 5 seconds remove the smear layer without removing the precious calcium in the dentin, right? So based on that, my idea was, if you use a non-acidic conditioning like sodium hypochlorite, you remove more the proteinic aspect, which means now the calcium in the dentin is intact. That was my understanding.
Yep. Okay. One of the issues when people are using glass ionomer is they say, oh, it gets fiddly when you've got to use polyacrylic acid on the dentine and you want to use phosphoric acid on the enamel margin, using the selective etching techniques. Some dentists they just throw it all out because they say, oh, it's just got too complicated. But so for those people, and this is based on Jeff Knight's work out of Australia, and he would probably be one of the best glass ionomer people on the planet. They did some studies looking at how long it took to shift the smear layer. So if you didn't put it on for any longer than 5 seconds, you sort of 2, 3, 4, that will remove the smear layer. But if you didn't want to go over 5 seconds, because then, as you say, it starts to remove too much mineral from the surface. But at 5 seconds, there's not enough degradation of the surface to actually affect the bond that glass ionomer makes to dentine. Now, GC will argue against that. They say you should only use polyacrylic acid, because it's a little bit, it's not quite as aggressive in removing calcium, though it will shift the smear layer. But you have to put it on a bit longer to make sure you've got the smear layer off, because if you don't shift the smear layer,
you would be positive and say that sodium hypochlorite does not remove smear layer, because that was new for me, honestly.
Yes, well, it removes smear layer to a level, but it doesn't sort of get it back to an absolutely clean surface that an acid will create, because it's an alkaline based material. So it's probably it's going to be breaking down the organic constituents within the smear layer, but it's not going to break down the mineral component of the smear layer. And on dentine, that's about 50-50 collagen and hydroxyapatite, with a little bit of handpiece oil and a bit of yesterday's lunch thrown in.
Yeah, I was basing my assumption on the study by Van Dijk, and it was in the 90s about the effect of cavity pretreatment. And there was another study showing that you can use EDTA plus sodium hypochlorite by Weiger in Europe. And
well, EDTA will definitely shift it, because that is acidic. But I just try to keep it as uncomplicated as I can. Dentistry is complicated enough, and if you've got to go through 10 bottles of stuff just to get your bond established, most people just are not going to do it. You've got to present people with the simplest options based on the best understanding we have at this time.
Absolutely.
I
The
can
other
always
thing
remember you
was
came out to New Zealand and did your lecture. The thing that stuck in my mind is when it was just this is just common sense. A lot of what we do. I mean, a lot of what I talk about isn't even in the literature yet, or there's bits of it in the literature, but all the pieces haven't been joined together. And most of what we're doing is common sense when you dig right down into it.
absolutely, absolutely.
That phrase,
I
that
just
stuck with
wanted
me.
I just wanted to clarify a misunderstanding with the super close sandwich, because there was a question. Of course, for bonding, you would apply glass ionomer to dentin, but the super close sandwich goal is not to bond to dentin, it's to decrease shrinkage stress effect. So it's the question was not asked in the good context. So basically, glass ionomer is a non-shrinking mega filler. So the super close sandwich goes from the literature knowledge that bonding of a resin bonding agent to dentin is much stronger than glass ionomer bonding to dentin. You may disagree with that, but as you said, glass ionomer, you cannot even test the bond to dentin because the glass ionomer will break cohesively.
Yeah.
So dentin resin bonding is the golden standard today. And for that reason, when you need to decrease shrinkage, glass ionomer is a fantastic tool to do that, because it's not going to bond strongly to the resin. And if there is shrinkage, gap will not open between the dentin and the resin, will open between the glass ionomer and the resin, which is a safe, selective bonding approach, if you will.
It's interesting. I never ever got involved with that that whole concept, because I was having so much success using Ribond and just proper glass.
Yeah, so that brings me to my next question. Have you used EverX, which is
I love it.
The new guy on the floor now, and I think there's a great promising results because it's very simple to use.
Yeah,
much simpler than Rebond, for instance.
Well, it's interesting when GC first came out with EverX, they sent me before it was in production, and being distributed. I played around with it for 6 months because they visualized they were going to use it as a bulk fill material because of the presence of all the glass fibers. But the glass fibers actually didn't have any positive effect on the resin shrinkage tension that developed on the bonds. And it was still possible using it as a bulk fill. If you put it into a cavity and you had quite thin enamel walls, you could actually flex the tooth inwards and snap the enamel. So I still use it incrementally, but it was an amazing material. It certainly gave you dentin replacement that was way stronger than anything else we've got out there.
And you know, I'm sure some of you have seen Matt Nejad's presentation where he did some very interesting experiments using glass tubes. And when EverX posterior was layered, like 3 increments of 1 millimeter, the effect of the shrinkage was much stronger than when it was bulk filled for 4 millimeter.
Yeah. But I think I use that. That's part of the. I'm going to be offering another presentation after the next one on how to restore endoteeth using this whole compression dome, ribbon fiber reinforcing the stuff to create a torsion tube inside the tooth. Relying on the fiber effects and how you can, and also the use of EverX.
I love this discussion. I'm having so much fun watching the two of you go back and forth and discuss. It's amazing. This is what it's all about. Thank you. This is great.
This is generally what happens after a lecture when everyone meets in the bar.
That's right. That's right. This cocktail hour.
I've got my gin.
This is like in Hawaii back in the 80s with Ray.
Yeah.
Hilton.
Hey, Dr. Lazar, you had and Dr. Milicich, you had a few more questions come in. Maybe you can take a look at those in the chat. You might as well knock them out.
Let's have a look. Let's get down to the bottom here.
When we bond to resin, a resin to a glass ionomer liner, can we etch the glass ionomer with phosphoric acid?
You will get some bond, but it's not as good as if you use a resin modified glass ionomer as an interface while it's still wet. So when you think about that, the glass ionomer in a resin modified glass ionomer, like something like Fujibond, you paint that onto the glass ionomer, that's the base. The glass ionomer will interact with the existing glass ionomer, and then when you put your composite on top, it will bond to the resin component of the resin modified glass ionomer film. That's the strongest way to connect composite and glass ionomer, is using resin modified glass ionomer as a bond interface.
Man, I think that we got all the questions there, don't we? Is there anything else I missed, Matt, that I'm not seeing?
Not that I'm seeing. I think we're good.
That was the last one that just came in. Yeah.
Oh, there we go. Saul had one. Oh, Saul, unmute yourself.
Unmute yourself and ask your question.
Hi. Yeah. Graeme, are you using? I know Pascal just brought this up about the Everex. Are you using still Everex in combination with Ribond, for example, in endodontically treated teeth? I know that's to come in your future presentation, but I'm curious.
So yeah, this is a lead up to that presentation. There's two away. Yeah, I basically wrap Ribond around the pulp chamber core and across the floor, and then there's still a big void in the middle once you've done that, and I fill that up with Everex.
Got it. Thank you.
And if there's also missing, well, I mean, the reality is if you're using ceramics like Emax, any missing dentine, you don't really have to replace, because that old adage, you have to have supported ceramics, supported porcelain. That only applied to the old feldspathic porcelains when you were fusing them to metal and stuff. The thicker Emax is, the stronger it is. So if you've got 6 millimeters of missing dentine somewhere, you don't have to replace 4 of that with Everex. You can replace the whole damn lot with your ceramic.
I understand. Cool. Thank you. Thanks for a great presentation, by the way. It was great. I loved it.
Dr. Milicich, I'm getting a private message from one of the attendees about just a little different explanation about the presentation we're going to have in 2 weeks, and then the third one that you're kind of hinting at. Yep. Can you kind of identify the differences between those two, please?
Okay, the first one is going to be explaining how a compression dome works and how Mother Nature has designed our teeth to work in compression, and anything that we do to a tooth starts to interfere with the Mother Nature's stress distribution system within the enamel cap and within the dentine. So we want to and I gave you a heads up on just one of those little structures called the subocclusal oblique transverse ridge that Tim Rainey identified back in '96. There's a bunch more. There's a whole bunch of mechanical concepts on how teeth work that we will be discussing, and then we'll be looking at, when we interfere with teeth, how they fail or why they fail, because we've got to identify the failure patterns, because each one requires a different technique to restore successfully. Some are very simple, others are incredibly complex. But until you identify the fracture pattern you've got, you don't know how to restore the tooth back to biomechanical stability. And then the second, so that takes care of the first, the next lecture. And then the one after that is advancing this whole concept a little bit further, looking at how you put endo teeth back together. And basically at the end of that, I'm hoping that I convince you never to suggest a full crown to a patient ever again. It's all about adhesive onlay ceramics.
Thanks a lot. Thanks a lot. Cool stuff going on. Thumbs up, everyone.